ADCY5, which means anything which antagonizes the adenosine A2A receptor will work beautifully in ADCY5. And we know that caffeine is a good antagonist of the adenosine A2A receptor, and that's why caffeine works very well in ADCY5. So there are certain clues when you see a child to see whether, okay, if I want one gene to test, should I test for ADCY5 or should I test for GNAO1? So the blurring boundaries we talked about, and then this is another child with rapid onset dystonia Parkinsonism, or ATP183 gene. Again, there are some clues because, if it is a child with early onset Parkinsonism, we would then. But the problem is even ATP183 gene is not just associated with Parkinsonism, it's also associated with other conditions. So, if you look at the classification, and if you look at how the isolated genes are put together, for example, the GCH1, the TH1, and the TAF1, these three genes are put together because they are all genes which are responsible, associated with disorders of dopamine synthesis and metabolism in the nickel neurons and present with Parkinsonism. But we know that although these three are put together, they are not the same. For example, the TAF1 is a neurodegenerative condition, while the other two are not. And for example, ADCY5 and GNAL are put separately, but we know that both are involved in the postsynaptic dopamine signaling in the striatum. So again, it shows that the current system of classification does not really help the practicing clinician. And this is a child with TAP4A gene mutation. But the reason why I put this is it's very important to know this concept that children with dystonia do not do things perfectly well. They don't do it like normal children do. But still, they have their ways of getting around their disability. And we have to take this into account whenever we approach the management of a child. It is not the particular gene mutation which is important. It's academically, yes, it is important to know like this is ADCY5 or this is GNAO1. But what's important is for the child, what is the ability to participate for the child? How does the child carry on in his day-to-day functions? And children with genetic dystonias do tend to have fairly good quality of life, and they have their own ways of getting around it. And that's very important to understand. So, multiple dystonia genes share the same biological pathways, and next generation sequencing has paved a way for precision medicine. And if, for example, if everybody could do whole exome sequencing, then the classification systems will become less relevant because we know, like, okay, you do whole exome sequencing, this is the gene, this is the treatment, that is it. But we are a long way away from that. So we still have a child we see in a resource-stretched setting, and then we want to give the best to a child. And classification systems based on molecular pathways to categorize the patients for targeting the therapeutic approaches are what's important. And perhaps we could use artificial intelligence, machine learning, etc. to try and compute all this data and explore further systems biology approach to try and make sense. Because like I said, the isolated dystonias, the genetic dystonias are only a small percentage of the children that we see in our day-to-day practice. The children that we see are mostly acquired dystonias. For example, this little girl is a cerebral palsy child with quite marked dystonia in her upper limbs. So although she has spasticity, she also has quite predominant dystonia which is affecting her quality of life. And this girl underwent deep brain stimulation successfully. Earlier somebody was asking about the role of deep brain stimulation in cerebral palsy. And it's very important because when faced with such a child, if you don't think in terms of the progression, in terms of the axis 1, it will be very difficult to decide whether to go down a particular route. And also other secondary dystonias or complex dystonias, because I don't think we should be using the term primary and secondary dystonias anymore. It should be either isolated, combined, complex, or complex dystonias like this associated with mitochondrial conditions. Because essentially, the management is all the same. Because the implications for dystonia will vary in every child, and the management should be tailored to the individual child irrespective of whatever the gene mutation is, whether it is acquired or primary dystonia. The goal setting and evaluation of the response and rational use of medication, personally I think we still have a long way to go to try and rationalize our polypharmacy approach. Because there are children who respond better to dopamine agonists, there are children who respond better to dopamine depleting agents, there are children who respond better to anticholinergic agents, there are children who respond better to neuromodulation like gabapentin, for example, and there are children who will respond better to deep brain stimulation. But if we end up in an unsatisfactory situation where the same child is on tetrabenazine, clonidine, gabapentin, trihexyphenidyl, that wouldn't be proper. And it's very important to see the child as a whole. And like I said, these children have different ways of coping. And they, like yesterday when Professor Gustri was showing the child with the arm stuck behind the back, there are all different ways of coping. And once we recognize the dystonia, and once we send the patient to the right treatment, then it can be quite life-changing. And as we already heard from Professor Doshi. So this is post DBS. So it can be quite life-changing, the right management. And this is important because the international classification of functioning, disability and health gives us the broad framework and common language and classify the function and disability. So while we are focusing on the classification of dystonia, we really also should be thinking about the classification of functioning and classification of the disability. And that's what the international classification of functioning, disability and health gives us. Because we have the health, then we have the body function, we have the activities, we have the participation, and they all are important because children with dystonia and other neurodisabilities do not do things beautifully, but they still do. It doesn't matter whether they does it like slightly abnormally, but what's important is they still are given the ability to participate. And sometimes, and like things like rational use of polypharmacy, etc., will go a long way towards improving their participation. Because there's no point in having multiple anti-dystonia medications and having a child asleep all the time, while preventing their ability to participate. And all these are very, very important. So what is the way forward? The way forward is collaboration, because as Alistair was also mentioning, the important thing is to upskill both research and clinical skills locally in countries where the conditions are more prevalent, and to educate both the caregivers and the patients. And luckily we have a very dynamic Child Neurology Society here in Bangladesh under the leadership of Professor Shaheen. And Professor Shaheen also works very closely with the International Child Neurology Association, but she's a member of the executive board. And I think this is the right time and opportunity to highlight the situation and work together to developing the pediatric neurology services, and particularly movement disorders and other neurodisability in Bangladesh. The ICNA, who Dr. Shaheen and I work very closely together. We have the Global Burden of Disease grants where we would invite the trainees to apply for, to look into these conditions and see, because there is pathology here, and then you can look at these conditions and see how we can make better sense of them. While the the attempts at classification are going on, and then there would be another like 5-10 years before somebody comes up with Axis 3, for example, looking at the pathophysiology. Meanwhile, it is important that like the children that we are entrusted with to look after, we don't do them a disservice. It's very important. And if there's any doubts or whether to look at explore more of ways of working with the ICNA, and as please contact either Professor Shakil or myself on my email. I think we'll be happy to take things forward. Thank you.
Many thanks, dear sir, for your eloquent and timely